All right, just to try to make an effort to get you all out of here on time, since it's such a nice day out, we'll go ahead and get started. My name is Jake Reese. I'm the Associate Program Manager for MCT2D. I'm going to kick us off this evening and get us through some administrative updates, and then I'll be passing it off to Dr. Heidi Deese, who'll be going through some clinical updates for us this evening. So before we get started here, this event is approved for CME. So in your folders, you will find a sheet of paper that has all of the instructions necessary. You do not necessarily need to text this number. The sheet in your folder has all of the information, and you don't have to do that by tomorrow, but this is just one option to do that. Additionally, on your tables, you will find a QR code on a sheet of paper. We do have a very packed agenda, as is our MO. And so if you do have questions, feel free to record those questions through the survey link that is through that QR code. If there is time at the end of the meeting, we will address all of those questions today. If not, we will compile our answers for them and then send them out to everybody in attendance this evening. All right, so here are our financial disclosures from our presenters this evening. And then these are all of the CME sessions or CME credits that tonight's session is eligible for. That includes medicine, nursing, and pharmacy, and social work and dietetics. All right, so here's our agenda. So as I mentioned, I'm going to go through some administrative updates for the first 15 minutes or so. And then Dr. Heidi Deese will be coming up to do some clinical updates. And then following that, Jackie will be talking through some exciting new resources and tools that we've put forth for a pre-diabetes initiative. We'll then have some future measure discussion with Dr. Oshman, and then we'll have case studies in both nephrology and endocrinology by Jenny Iyengar for endo and Dr. Mike Hong for nephrology. All right, so let's dive in here to talk about some new resources, education, and tools that we've put together since the last time we saw you. The big one here is what we call our MCT2D print shop. We know that one of the main things that we've created for you all is all of the resources and tools that are available through the MCT2D.org website through the resource library. We do bring many of those tools to these in-person sessions. They are available on a table at the back of the room here tonight. However, we only see you guys in person once a year, and lugging some of those, so many of those tools around can be cumbersome. And so we've put together our print shop. And so this is available through the MCT2D admin portal. We will have these resources printed and shipped to you at no cost. We are starting a small beta approach where we're going to have 200-page limit per practice, just so we can kind of get a gauge as to uptake and cost, because a lot of it's just estimation at this point in time. But you all, if you have admin portal access, you can go in and order that for your practices. If you have multiple practices in the same area and you have a physician organization representative that you work with closely, if you're willing to have them shipped to the same location, that helps us save on shipping, but that is not required. If you don't have admin portal access, please talk to your physician organization representative and they can help order, because they can order for the practices within their PO. And so speaking of resources, here are some new resources that we've developed recently. So we've been working closely with our endocrinology leads to develop 5 new resources, for getting patients with type 2 diabetes started on insulin who need insulin. You'll find these resources on the back table for this evening, as well as on the MCT2D resource library. These include understanding the basics of both long-acting and prandial insulin, addressing hypoglycemic concerns, and the use of glucagon. These tools are also available for feedback for a physician-level learning community requirement through the administrative portal, and providing feedback on that will meet that physician-level VBR requirement. All right, and then Dr. Lauren Oshman has put together an update on weight management medication. This is very similar to how we do our live learning community events. However, this was just a pre-recorded one. It is available now live on our YouTube channel. It is live on our YouTube channel now. And this is also available to watch and complete a short 5-question quiz on in order to receive your physician-level learning community requirement as well. This one talks about a review of the first generation of weight loss medications, an overview of the new medications that have come out recently in 2026, including the Wegovy pill and now Foundayo just a couple of weeks ago. And that link was sent out for this back in mid-April and can be found in the quiz can be found in the quiz section on the admin portal. If you have any trouble finding it, just reach out to the CC team's email and we'd be happy to help you. A couple of other videos that we've recently created. So Dr. Mike Hung, who you'll be hearing from this evening, has recorded both a provider-facing and a patient-facing UACR overview video. The provider-facing video focuses on the importance of UACR testing in patients with diabetes, as well as an overview of both the KED HEDIS measure that focuses on both UACR and EGFR testing, and as well as the MCT2D UACR measure and how those two different measures differ and how they have some similarities. Um, the patient-facing video really focuses on why getting a UACR test is important, what the measure tests, what the results mean, and trying to really engage the patient as an active member in their care. We encourage you to check out these videos. They are available through the resource library and are live on our YouTube channel. For the learning community events, there is a learning community activities menu that is available through the administrative portal. You can also go to mct2d.org and click on learning community button at the top, and that'll actually re-navigate you to the admin portal automatically. So it's kind of either way you can get there. All the details of the physician level and practice level learning community options are available there, and where you can find all of the necessary links and information for all of those opportunities. It's also where we'll be continuing to post new opportunities as they become available throughout the performance year. All right, so shifting gears just slightly here over to updates on the dashboard and measurements, performance measurements. So if you haven't seen already, we did send out an email for this back on April 14th, but we were really excited that we were able to complete our full transition over to Dashboard 2.0. So this is our fully redesigned patient data dashboard portal, and this includes redesigned patient profiles and patient list pages that now join our summary measures page on the new platform. And so this is a quick overview screenshots of what those two things look like. The image on the left here is of the filters for the patient list. This is what we refer to as our patient identification tool. This is what allows you to filter your patient list by a number of clinical criteria of interest to you. For example, one may be to find patients that may be a good candidate for getting started on a GLP-1 receptor agonist, or maybe who have chronic kidney disease and could benefit from an SGLT2 inhibitor or something along those lines. You may recall from the previous version of the dashboard, there were two sides of it. There was the patient list and the renal details. That was simply because we ran out of room to have all of the filters on the same page. We've fixed that issue now, and so this is a single unified patient list with all of the filters for both diabetes and kidney-specific labs in one place. The image on the right-hand side is a snapshot of some additional new visualizations on the patient profile. So you'll see here on the top of that right-hand screenshot is that we have trends, and you can hover over these just as you could before, but the thing that's really new is the trends for medications on the bottom. And so instead of just showing active medications, you can now see the history for a patient of their medication profile. And so you can see if they transitioned off of a certain med and started a new one and when that happened to have occurred. We also include on here whether or not they're overdue for certain care testing, such as A1C or UACR testing, which is a greater than 12-month time frame. So performance measure reporting, we have all of the push reporting, the PDF progress reports available through the administrative portal. We distributed the PCP A1C report in late February, which had data through November 30th. And then we will be sharing the final report for the A1C performance measure in July that'll encompass the full performance period ending at the end of this month, so the end of April 2026. On March 31st, we distributed the progress reports for the UACR measure for both primary care and nephrology, and the endocrinology CGM interpretation measure as well. The next reports for these will be coming out in August, which will have data through the end of June. And then the final reports for those three measures will be coming out in February 2027, which will have all of the rest of the performance period data through the end of August. And so these can be, as I mentioned, found on the administrative portal through the button titled MCT2D Practice Performance Reports. If you don't have portal access, please reach out to your physician organization representative and ask them to send you your practice's performance reports for your performance measures. All right, and so this is our timeline on the data releases. I mentioned a couple of these as we were going through the reports, but you can see here that the April 30th refresh, we were actually a little ahead of schedule, so this one's already been pushed out. So the data on the dashboard right now is currently through February 28th, 2026, and then our next refresh will be coming in the end of June, which will bring our data through the end of April. And you can see here that that one is, as I mentioned, what's going to be able to finalize our A1C measure. And then the refresh in October is what will bring our data through the end of August, which will enable the final performance reporting for the other three performance measures. All right, so speaking of performance measures, these next few slides that we're going to talk about are data through January 31st. That's when we were able to do this analysis. And so for the three performance measures, the three outcome measures, the PCP UACR, the nephro UACR, and the CGM interpretation measure, that January 31st time point represents exactly the 50% mark, the halfway point in the performance period. We'll talk about what that means. But first, we'll look at this A1C measure, and you can see, because the A1C measure is our one outcome measure, everybody's performing exceptionally well, as we would expect. And so we know that the 90th percentile rates were increased this year from HEDIS, which is what we follow for this performance measure, by approximately 4%, going from 70% for patients with an A1C less than 8 for commercial to 74.45, and then from 87% for Medicare patients with an A1C of less than or equal to 9, excuse me, to that new target of 91%. And so we do recognize that this increased a little bit, and so we'll talk about scorecard and how that was impacted here in a second. But you'll see that out of the 339 practices, 333 are meeting the measure for commercial, and 326 are meeting it for Medicare. So exceptionally well across the board, and you can see the current averages for Medicare and commercial there represented as well. So as I mentioned, we did adjust the scorecard scoring for this to address the fact that these target rates did increase based on HEDIS, and that it increased after the new performance year had already started. And so there is a tiered scoring mechanism on the scorecard this year for the A1C measure. If your practice meets the 2025 HEDIS measure, so the same as last year, rates, you'll achieve 15 points instead of an all or nothing, and then achieved a rate of at least 72% for commercial and 89% for Medicare, you'll get 20 points. And then if you meet that new 90th percentile rate of 74.45 for commercial and 91 for Medicare, you'll get the full 25 points. And so this is just a quick visualization of performance over time for the A1C VBR measure. You can see that since the very beginning, we've increased for our commercial from 84% up to 88% as a collaborative average, and then a little bit more modest for Medicare because we were already all performing so high from 96 to 97. Oops. All right, and so for the PCP UACR measure, as I mentioned, this data represents the 50% mark, the halfway point in the performance period. And we're a little bit behind the 50% where we would expect practices to be on track for. You can see that 44 out of 339 is what we would define at this point in time as being on track. That is what we mean by that is having met 50% of a practice's individual practice target. You can see here that the vast majority of practices, 274, are in that 25 to 50% of their target range. And so we just wanted to show this. This is not to say that anybody's at risk of anything. So we know that practices oftentimes are getting patients in for their UACR screening at the beginning of the year. As I mentioned, this data is only currently through right now on this slide, January 31st. So we know that these patients are going to be get seen. So we're expecting to see an uptick of this as the year progresses. Keep clicking the wrong button. And then on the other hand, nephrology, we have a much smaller N value for this. We only have 14 nephrology practices. So you can see that 12 out of the 14 nephrology practices are actively meeting this measure currently, which is fantastic. So we actually only have the 2 that are below that 50% of their target range right now. You can see the same graphs here, but you can see the vast majority of those 14 practices are in the 50 to 75 percentile range here. All right, and then finally here for our endocrinology CGM interpretation measure. So this one's quite interesting and fantastic progress on this one. For all 21 practices are on track to meet their measure right now. You can see the vast majority are in the 75 to 100% range for their target rates, with 6 out of the 21 practices having already met their target rates. We've seen major gains in these measures. We know that some practices, this performance measure represented a shift in policy. A lot of practices weren't previously billing 95251 at all. And so that accounted for low baseline rates as well as a rather simple way to meet their performance target once they started doing that altogether. But we're seeing very good performance across the board with a current average of 81.4, which is almost at our baseline average, and we're only 50% of the way through that performance period. All right, with that, I'm going to turn it over to Dr. Heidi Deese to go through our MCT2D clinical updates for the evening.
Yeah.
There's a separate link here if you'd like it.
Okay. Hey, everybody. Welcome. Jake, real quick, are we doing the QR codes or no?
Yes, yep, maybe that's on there too.
And did we talk about that or oh, sorry, what's that? Spending my food. So welcome, great to see you all again. So tonight we're gonna start off with a case. So we're gonna talk about Martha. So she was referred to me about 6 months prior to the visit that we're gonna talk about. She lives up north and she sees several specialists outside our system. And so some background information on her. These are prior to the 6 months prior to this visit that we're going to talk about. She was tapered off both her basal and prandial insulin because one of her specialists added Jardiance and then tapered that dose up to full dose. And then today at her visit, Martha apologizes. I had ordered labs to try to get them ahead of time and she forgot to get them ahead of her visit. I said, no big deal. But as you can see, her A1C is excellent. She's doing well on her triple regimen, and she is really proud of her recent 23-pound weight loss. So here's her CGM data that she did have for me. And so as you can see, her glycemic control is excellent. She's at 95%. Her capture rate's at 70%. She doesn't have any lows. Her GMI is at 6.4. So my plan that day was, given that she's motivated, she's losing weight, and her CGM data was still good and well controlled, I decided to wait till she could get those labs for me, and I was going to have a follow-up visit with her and see what went on when I got those labs. So about 8 weeks later, I saw her again. She returned for follow-up, and she reports having a few rough days. She said she had been vomiting, and then she said, I just took my second dose of Mounjaro, 15 milligrams. And I said, can you repeat that dose? And she's like, yeah, my specialist switched me from Trulicity 4.5 milligram to Mounjaro 15 milligram. I said, oh, okay. So I looked over her CGM data again, and this is what we got this time. So largely stable time in range at 89% here. Sorry, it's a little, I couldn't get as clear of an image. No lows again, but as we also know, even though the AGP might say 0, we're going to go through those daily reports. And so upon doing that and asking her about, I did see some lows on that daily report. And when I asked her about those lows, she did have symptoms and she did poke her finger, and she was in the 60s when she tested. And so even though that capture rate was below 70, so glycemic control might not be entirely representative, we needed to take some action because she was having symptomatic lows. So I went ahead and lowered that tirzepatide down to 5 milligrams. And we left her there for quite some time. And this was a little while ago when this case happened. So it was in the time frame of the lovely Mounjaro shortage of 2024. So we had to eventually switch her off to a different GLP because we couldn't get it. But I bring this up because unfortunately, Martha's case we see often. And so it does nicely illustrate, though, a new update that the ADA had this year. And so when GLPs are used in our patients with type 2 diabetes for weight loss, individualized dosing should be used. And it needs to be used for the effectiveness, health benefits, but we need to balance those with side effects, tolerance, and this is the key. The optimal dose might not be that max dose that's on that package label. And I was so happy to see that the the ADA, said that, because I see it all the time. I see these like batch prescriptions going out, just ramping everybody up to the max dose. We don't need to do that. See how the patient tolerates it, and maybe they only need, in Monjaro's case, 7.5 or 10. So anywho, as a reminder, in December, we renamed our GLP shortage, fingers crossed, to the switching guide, because hopefully we don't have to deal with any more shortages. I also want to point out, we decided to make a class designation change from incretin mimetics to GLP-based medications. This is just kind of for also consistency and ease of understanding between some of our patient and clinician-facing tools. So, it's a little bit of a nomenclature. I also want to point out that this resource could have really helped the specialists in Martha's case. And so as a reminder, here in this equivalent therapeutic dosing, this caret says that this is therapeutic dosing. So I remove the sensitizing dosing from this table. And then next, if we look down where she was on that Trulicity, there is no equivalent dose of Mounjaro because it's more potent. So then if we weren't looking to further lower her A1C or help with weight loss, we could have just gone over to that 5 milligrams. But perhaps we were maybe trying to help Martha jumpstart her weight loss journey. Then that 7.5 milligrams could have been more appropriate. All right. So moving on to some other ADA updates. This should look pretty familiar by now. So this is the new algorithm for 2026, largely unchanged from 2025, but a few minor little changes I wanted to bring to your attention. First, over here to the left in this yellow box, a terminology shift. So they are moving away from the use of A1C and we're using glycemia. And I think this is really nice because I think it's reflective of the increased use of CGMs. We then have this aqua box here for patients with heart failure with symptoms. And so this is either patients with HFrEF, so reduced heart failure, or patients with HFpEF, those with preserved ejection fraction. And the role of SGLT2s is clearly called out here. This isn't anything new. This has been known for a long time. But it's just really making that delineated path really clear. What is new is this orange box. So this orange box is for patients with symptomatic heart failure with preserved ejection fraction and obesity. And so the recommendation now is the use of SGLT2 inhibitors, of course, and or GLPs, GLP-based therapy with proven cardiovascular benefits. And so we're seeing yet another pathway for our GLPs with the cofactor of obesity. And then finally, we saw an elimination of continuing SGLT2s until dialysis or transplant. Again, was removed from this section because now we can continue SGLT2s through dialysis. And so Dr. Hung is here and he's going to be going over some renal cases later. And so if there's questions about that, we can certainly address that then. Okay, so moving away for a little bit from ADA updates. About a month ago, we had some big changes in the new dyslipidemia guidelines came out. And so this is published by the American College of Cardiology and the American Heart Association, along with 9 other collaborating organizations, including the ADA. And these are to replace the prior guidelines from 2018. We don't have enough time to go over the complete 123-page document, so I've condensed it for you in 2 slides. Big picture here. Here's for our patients with type 2 diabetes. Not a big change from what we've been doing for the 2025-2026 guidelines. So you can see we're still going to use moderate to high intensity statins in most of our patients. But if you look to the far right of this chart, we're back to having lipid targets. So lipid targets are LDL targets are back. So that's probably the biggest change that we're going to see. Some of us might have been already doing this. Next is for the extremes of the ages. So for our patients that are under the age of 40 or over the age of 75, these LDL targets are meant as a conversation point to talk. It's not like a mandate to start a statin or they have to be on a statin. It's meant to talk about where their LDL could be and whether we could talk about lifestyle interventions or perhaps a statin. Next is the role of ezetimibe. And for any patient who is not meeting their LDL target on maximally tolerated statin, we really should be adding ezetimibe to these patients. It's cheap, it's generic, it's really well tolerated, doesn't really have any side effects. So that's really highlighted for our patients. All right. So what are the other key updates for all the other patients you see that do not have type 2 diabetes? I've already talked about LDL goals. Next is there's a new risk calculator. You may have already heard about this, the PREVENT calculator. And so this is more representative of our contemporary populations. So there's a younger age threshold, as you see up here, so down to age 30, up to age 79. This also includes now the calculator does renal function. So you're going to enter their GFR, you're going to enter their A1C, statin use, and it's race agnostic. Another big new recommendation is that every adult is recommended to get a lipoprotein A level. And if the level comes back equal or over 50, that patient is considered high risk. So then you might ask, okay, then what? Do statins target lipoprotein A? No. Do we have any drugs that target lipoprotein A? No. So why are we doing this? We're doing this because it identifies patients that are at the highest risk. Then we would intensify treatment. We might talk about what we could do to, maybe they're not on any therapy. This might then be a reason to start really focusing on their overall cardiovascular health. Next, if this probably isn't enough information for you, so if you want a little additional information, you might want to get out your phones. This QR code up here behind me or over my shoulder is a 7-page abbreviated summary written by a PharmD that sits on the American College of Cardiology. It's got some great infographics that I highly recommend using and just reading because it's just a great summary of the guidelines. So that's why I included it. And then finally, the overall thing is just earlier intervention, earlier conversation. It doesn't mean intervention in the form of medication. We're talking about things. We're talking about where their levels are. We're talking about lifestyle. So that's really the take-home message. And then finally, this is one of those infographics from that article. And along the bottom, you'll see that arrow, and it's promoting lifestyle. So lifestyle is definitely a theme that I really was happy to see in these updates. Okay, so I'm going to spend like 2 seconds on this. I'm going to say new pill with air quotes because there's nothing new. All they're doing is we were supposed to be getting this Ribelsis 2. We've been hearing about this for a while. It's never going to come to market. It's going to not come to market because instead of Ribelsis 2, it's going to be called the Ozempic pill. So when are we going to see it? Supposedly we're going to see it Q2. If I had a crystal ball and I was like, into making predictions, ADA happens to fall in June. I have the prediction that I bet it happens to appear in June because I bet they're going to announce it at ADA. So we'll find out. We'll find out if that happens. Once we have more information at MCT2D, we will let you know about it. But that is all I know at this point. All right, so last bit of ADA updates is regarding CGM use. And only to simply say there's a ton of words on this slide, kind of intentional. I was really excited when the guidelines came out in December, and I remain very hopeful. The word consider was removed. Our patients were put in with the word recommended, CGM recommended. Now, is it the same level as everybody else? No. But is it perfect? No. Do I remain optimistic that eventually we're going to get to a point that patients with type 2 diabetes, regardless of what therapy we're on, are going to get covered CGMs? Yes. Are we there yet? No. Am I going to continue to advocate? Yes. And that's all I have to say on this topic. So there you go. All right. So before I get into prescription CGM updates, I did want to highlight the tool that we have for over-the-counter CGMs and highlight some updates on these CGM products. So we have Stello, Dexcom's products, and Lingo, Abbott's CG over-the-counter. Both now have the indication 18 and over with prediabetes or type 2 diabetes. They just cannot be on insulin because remember, these do not have any alarms. That's the only caveat. Both products now have the option for patients to get just one sensor. But it does come at the cost of $50, and there's nothing you can do to lower that cost right now. So I understand it's not affordable for all patients. I get it. So it is what it is. I'm just sharing what I know. The Lingo, though, now is available at Walmart and some Walgreens, I think. It's on our form. I can't keep it all track, but that is the only of the two that has some at least box stores that you can go to. It's been typically just online. And then finally, both of these have apps that have built-in AI behavioral kind of coaching built in. And so I think clinically, that's where I've used some of this in my patients that are kind of, they'll sometimes say, I want a Dr. Heidi. And so, well, Dr. Heidi can't be there all the time. So this is a great option for some of my patients that they also might say, I don't want a GLP. And so I just need help understanding what food is doing to my blood sugar. Well, this is perfect. And it's great because I don't know, I've had some success with these, and then they can buy it when they need it. Again, I get affordability as an issue, but just sharing that because I think actually the over-the-counter devices have some nicer behavioral coaching than the prescription ones. Okay, so moving on to prescription ones. You likely have already heard that Dexcom G6 is being discontinued as of July of this year. So if you have any patients that are on a G6, you need to get them switched over to a G7, either the 10-day or the 15-day. If it were me, I think I'd be switching them to the 15-day because then they only need 2 sensors a month. Distributors have already stopped getting them, so the pharmacies are going to start not getting the product anymore. Warranty for said sensors and readers will stop at the end of 2027. And what do you need to know? Get your patients over to a G7 of some sort so they can continue to have their CGM, is what you need to know. And then as it pertains to the G7, they are available at both the pharmacy and DME now. For a while, it was like only at DME. They're available at both places. Each place has plenty of quantities. Pricing is the same. So it's the same between the 10-day and the 15-day. It's the same whether it's at DME or pharmacy. Minor differences are listed here between the 10-day and the 15-day, between warm-up time and the grace period. When I was meeting before regional meetings, I always meet with the MSLs to kind of get any sort of updates that I can share with you all. And they were really excited to tell me about this updated algorithm. And the first day algorithm is supposed to really help with the variation that some patients see when they put that new sensor on. It can be a little wonky. It's supposed to help even things out. I don't have all too many patients on Dexcom, so I haven't seen that clinically. I don't know if any of you have seen that or gotten feedback from your patients, but certainly I've asked a few patients, and I will continue to ask if they've seen that, but just wanted to share that with you. Moving on to Abbott. So I don't know if you've heard about Libre Assist. And so this is the behavioral component that Libre has. And so this involves a patient taking a picture of their plate of food. And it's a two-phase kind of feedback for the patient. And there'll be a next slide to really give you a visual on this. And so it offers AI-assisted feedback on glycemic index of food. So it is not giving them carb counts. It does this initial insight. And then after the CGM has kind of gotten the glucose from their data, it then gives them feedback in terms of what they could do next time. So we'll get there in a second. And then the other thing is they've added Apple Watch integration. So if patients have an Apple Watch, it's going to mirror what they see on their phone to their Apple Watch. So if they don't always have their phone with them, they can see their data on their watch. I did ask if they have any plans or if it's applicable to Android watches, and they said no. Unfortunately, I've asked before, and I think a lot has to do with the various Android products and the number of operating systems. When it comes to iPhone, there's just iOS. And so I do think that's why we see so many kind of focused iOS things. So this is just to give you an idea of what Libre Assist looks like. So if you focus on that middle image of the spaghetti, when patients take a picture, they then get the Libre Assist pops up and it says, you see that little orange box that says predicted major impact. And then the next one, it goes to, it's starting to identify. So Parmesan cheese, it's green. And then it says meat sauce, like mild. And then spaghetti, warning, so a higher glycemic index. And then what's cool is tips to try underneath. It's trying to coach the patient to say, maybe you could try whole grain pasta. Perhaps you could add a side salad. So again, just trying to help patients make smarter decisions. So I've had some patients, I was really excited to tell one patient, and I was going into the video visit, and when I got to the CGM data and I started to go over the comparison, he was like, hey, guess what? I started using this Libre Assist. I was, oh, I wanted to tell you about that, but I can be funded. All right, and then last update here, Abbott, is always trying to work with us in terms of helping our patients. And so as we all know, there was lots of coverage changes earlier this year. And so for our commercial patients only, so again, this is not applicable to Medicare, Medicaid, or uninsured. But if a patient has commercial insurance and they have a claim for sensors that go at a pharmacy that is in the state of Michigan, there's a couple of caveats here. If they've previously been using a copay card, as we all know, there was a copay card at once that reduced the out-of-pocket cost to $75. They have to tell the pharmacy staff to remove that, because what's important here is the commercial insurance needs to reject the claim. Upon rejection of the claim, they've set up this pilot program in our state to then offer a savings, which I'll show you here in a second. They don't have to sign up for anything. They have to get a minimum of 2 sensors. They can't get 1. They can get up to 3 months if they wanted, but it's going to lower the price to $49. So they could get every month 2 sensors for $50, or as we've talked before, they could do 2 sensors and wear a sensor for 2 weeks each month and just pay essentially $25 each month, and try to space it out over 2 months. This is a new updated worksheet. We used to have meds, CGMs, all in one, and now it's just a CGM worksheet, but I think it's kind of the most cumbersome thing we do. It's the hardest, so we added a lot more information, and this has gone through 2 rounds of our patient advisory board. We got a ton of feedback, and the last time we took it to the patient advisory board, it got raving reviews. They loved it. We added information about like whether it's medical benefit, whether it's a pharmacy benefit, and really detailed ways of how they can talk to the insurance companies and try to just help the patients navigate this, trying to help you too. So they're not coming to you, they come to you with, hey, I figured out it was covered. So new resources at the bottom, step 6, I made a table in case they find out it's not covered. It's estimates of cost of what they would go and say to their benefits office for HSA, so they could try to get coverage from an HSA if they're working. All right, and then finally, back in November, we sent out a request, if you might recall, for patients not using insulin, because we wanted to do a survey to figure out how patients were benefiting from CGMs. And so I quickly wanted to share the results of our survey. So we had 32 patients respond to our survey. And we had 97% of them report that their A1C was lowered. One patient did not see any lowering. Their A1C stayed the same. And then here is a quote, and I love how the patient here describes how the CGM allows them to monitor for a food reaction. But the best part I think here is the secret sauce of a CGM. It's that the CGM has been critical in changing my eating habits. And I share this quote when I'm meeting with payers and trying to explain to payers really what, again, the secret sauce of CGMs are for our patients with type 2, not on insulin. It's this. This is what CGMs do for our patients. So I was really excited that a patient said this, because then I don't have to. So then we asked a unique question. If you could design your own insurance plan, would you rather have coverage for a GLP-based medication or a CGM? So 47% of them said they would choose a CGM over a GLP. So here's some quotes around that question. The CGM puts the responsibility of glycemic control in the patient's hands. Another patient said, I achieved greater health with the use of CGM, and they never want to go back to GLP-based medications, even if they were free. So I thought that was pretty powerful. And then often when I meet with payers, they tell me patients don't want to pay for a CGM. They want a zero copay. They don't want to pay. And so I said, all right, well, let's ask the patients what they want, right? We can assume, but let's ask. So we did. So over 90% of patients said they're willing to pay a copay. Patients want CGMs, like they'll pay a copay. On average, we did a slider rule. So they got to pick from $0 to $100. They could put it up. So they picked $33 a month they would pay for a CGM. Only 3 patients out of our 32 said they didn't want to have a copay. And then finally, one last policy change. Lots more words on this slide. The takeaway message is this whole modifier 25 reimbursement business with Blue Cross, it is not going to impact what we do with CGM interpretation. So when it comes to CGM interpretation, you don't have to worry about anything. It's not changing. Where you use modifier 25 with other things that you do, I don't know, so I can't comment. If there's questions, please use the QR code. I will be here till the end, so I'm happy to answer questions at the end. And now I'm going to turn over to Jackie.
Hi, everyone. I'm here tonight to talk to you about our diabetes prevention initiative. So in response to a request from the collaborative, when we were asking after CGMs, low carb diet, medications, what else you wanted us to focus on, the response was overwhelmingly around prediabetes. So we launched this initiative starting in 2025, and we're excited to share an update on the development of our new prediabetes tools. So let's start by reviewing the key recommendations from the ADA primary care update in regards to prediabetes. So the ADA emphasizes that prediabetes is a critical window for action as it significantly increases risk for type 2 diabetes, cardiovascular disease, and other metabolic conditions. They recommend screening higher risk individuals early and often, prioritizing lifestyle behavior around improvement of nutrition, activity, and sleep. They also recommend referral to comprehensive programs like the Diabetes Prevention Program. And they discuss the consideration of medication like metformin for patients who could benefit from pharmacologic support. But we know that implementing the guidelines can be challenging, so we wanted to learn from you on how we could support guideline-directed care in practice. We started at our collaborative-wide meeting where we learned from the PO representatives about what barriers and opportunities exist to screening for and caring for patients with prediabetes. We also ran online focus groups, inviting collaborative members to tell us what tools and resources would be the most helpful and for feedback as we develop these tools and resources. So you told us that you needed free resources for patients, more awareness about DPP and DPP coverage. You had questions about who to screen and how to bill for it, and for tools to support conversations with patients to help decide if and what lifestyle changes they would engage in. So we learned from you to develop our prediabetes initiative. And then lastly, we surveyed you at our fall 2025 regional meetings to make sure that all of our clinical champions had an opportunity to add to this conversation. You re-emphasized those needs for patient education materials, for actionable tools to help patients make lifestyle changes, around the importance of DPP access and awareness, and the additional support to navigate cost and coverage across all of these treatment strategies. And then from all of this information, we identified 4 key areas that we as a collaborative wanted to focus on as part of the prediabetes initiative: clinical workflows, awareness and education, data and tracking, and coverage and access. And we're just getting started, but here are some of the areas of these 4 that we've begun work in, and we can't wait to continue as we expand this initiative. Our first resource was to answer your question, what is prediabetes and how and when do you screen and bill for it? So you can find this resource both in our resource library and at the QR code listed on this slide here. This resource provides a clear definition of prediabetes along with guidance on who to screen, how often, and additional considerations such as patients that you may want to screen at an earlier age or at a lower BMI. We also know that billing and coding is a very common question, so we included guidance for this on the back of this tool, including common codes and the covered screening frequency. With this resource created, we began exploring how to support patients in navigating and accessing prediabetes treatments. To do this, we wanted to build on our successful Jumpstart model, which is our low-carb diet website, by creating a standalone web platform that offered a patient-guided journey to resources and actionable next steps. Something that could act as a one-stop shop of information when you're having these critical conversations with a patient. So this work was guided by our amazing team of clinical experts led by our fantastic Dr. Jonathan Gavison alongside our patient advisory board. Our PAB helped shape these tools and will continue to provide patient-centered guidance as we develop them. One example of this is our patient advisory board told us that instead of just prediabetes, they liked the term metabolic health because they felt that this was a shift away from restriction and it resonated with people. So you'll see that language reflected in our tools and resources. With this guidance and support, we identified 7 diabetes prevention strategies: movement, continuous glucose monitors, DPP, nutrition, medication, stress management, and sleep. We then began designing our prediabetes platform to help a patient understand the importance of the prediabetes diagnosis first, and then have what we like to call a choose your own adventure experience, allowing them to select which strategies that they're interested in hearing more about. And then based on your feedback in conjunction with the online content, we've developed a print-ready handout for each of these 7 strategies. In your folders, you have a sample of each of these handouts. They're stapled together in there, and you can also collect more at our resource table in the back if you want to take some back to share with patients. And we wanted to give you just a quick highlight of the content on the website. So we're actively working on the digital experience, and you're going to see new features, updates, and improvements happening regularly over the next couple of weeks. So first, you emphasized how critical it was to communicate to patients about the importance of early intervention. We wanted to make sure that our website started with a call to action, telling patients that the choices that they make today can shape their future. And whether they were diagnosed with prediabetes 3 hours ago or 3 years ago, it's not too late to make changes that protect their long-term health. You'd also wanted information that explained why preventing prediabetes was important and discussed the complications that we're trying to stop. We built this into our Understanding Metabolic Health and Prediabetes section, which also includes other helpful information like what an A1C test is and how to understand metabolic health lab results. Here you can see an example of what that content looks like. Again, trying to explain these concepts clearly and simply and provide information that patients can take home either as a printed handout or find online. We wanted to include messages and stories from other patients, and this is something we plan to continue expanding throughout the site. Our PAB members shared messages about why they made lifestyle changes, like one patient sharing that their mother was an amputee due to type 2 diabetes and they didn't want to go down that same path, so they focused on how they could improve their lifestyle. Patients can access information on each of those 7 strategies, either in a top menu or by scrolling down on the page. So here, to help them get started, they can select strategies they're interested in learning more about and then click See My Strategies. This takes them to a custom menu of prevention strategy highlights. These highlights share a brief overview along with information on the cost and actionable next steps. They can choose to select and download strategies as a PDF or click on a strategy to learn more. So let's take a look at one of these strategies. For the most part, each one starts with a how it works section, like in this example, explaining how a CGM works and what it looks like. Each strategy has a pros and cons section, helping create transparency for patients so that they can make an informed decision about which strategies they want to try. Next, patients can find a brief section on insurance and costs. In our CGM example, this section provides more information on the 2 over-the-counter options and how they can use a HSA or FSA account to buy them if that's an option for that patient. For many of the strategies, the page includes links to additional tools and resources. In our CGM example, patients can link our new comparison guide for choosing between the Stelo and Lingo over-the-counter CGM options. This tool is also available in our resource library, and again, we have physical copies on the handout table in the back as well. And then each strategy has a next step section, helping patients to guide them into action if they're interested in trying that strategy. Some of the strategies include goal setting sections, helping patients set personal starting goals. For example, for our movement strategy, we have taking a 15-minute walk after their next meal as an example of how to get started. Across all of the strategies, we tried to focus on making small, sustainable adjustments that would feel digestible to patients, such as this example for nutrition, recommending that patients focus on adjusting their diet using a simplified stoplight approach. And again, providing them with the tools to help support these adjustments, which leads us to another new tool, which is our low-carb recipe generator. So credit to our amazing team members, Julian and Kit, for creating this tool. We heard from the collaborative how helpful things like meal plans were, and our meal plans are often our most downloaded resource on our website, but we needed to create more options that were flexible to fit with cultural and dietary preferences. So in response, we created this AI-powered low-carb recipe generator that can create and customize an unlimited number of recipes based on inputs from the user. And to ensure consistency and accuracy of the nutritional information, our team created a multi-layered verification process that ensures that all nutrition information is validated through the USDA food database. And so we have numerous customization options for Satisfy. You can choose the meal type, the number of servings, the cooking difficulty, time, and method. You can choose a cultural influence with over 250 cuisine types and food traditions represented. We also have a section for dietary restrictions. So if someone's gluten-free or vegan, they can get meals that are customized to those dietary restrictions. And then finally, we can choose things like the number of carbs, a maximum number of ingredients for a recipe, a flavor profile, and the option to include or exclude specific ingredients based on what's available in the patient's pantry or like foods that they might not like or that weren't captured by the dietary restrictions portion. And so not only can you create custom recipes, but you can also low carb an existing dish. So helping patients adapt their favorite dishes to a lower carb lifestyle. So you can put mac and cheese or pizza and be given a lower carb version of that. And then lastly, we're so excited to share another new resource that's designed to help motivate patients make lifestyle changes. So our new food tracking booklet can be found on our prediabetes website and in the MCT2D resource library. We also plan to have the booklet available through our print shop that Jake had mentioned earlier. We want to share a big thank you to Michelle Smith of Southwestern Medical Clinic, both for this idea and design. She attended one of our prediabetes focus groups and generously shared the tracker that she'd made to use with her patients with diabetes. And then her fantastic tracking tool served as the basis for creating this version to support our prediabetes initiative. So to close us out, looking into the next few weeks, you'll see lots of updates happening on the prediabetes website, including improving our mobile optimization and launching new tools like our metabolic matchmaker, where patients can complete a survey and get matched with those different strategies, and adding to our DPP program map and more. And then later this year, you can expect to see these web and tool updates continue, as well as the addition to our prediabetes data to our MCT2D patient data dashboard so that you can track those patients there as well. And with that, I will hand it over to Dr. Ashman, who's going to talk us through some future performance measures.
Thank you so much. Well, it's lovely to see you all and lovely to be here. Thank you again for every night that we ask you to come in after work. We give you good food. We hope it's a little bit interesting. Will folks raise your hand if you're from an endocrinology or nephrology practice? So welcome. I feel badly because I feel like we're not highlighting your exceptional skills tonight. I also feel badly because we don't have a break. So if you need to leave the next 3 minutes, it's important, but feel free to take a break, walk if you need to, get some extra cake or some coffee. And I'm going to transition us into talking about performance measures. And really, what I'm here to do is to talk about our 2 performance measures that we've put into place so far, A1C control and UACR measurement, and to think carefully with you about what we want to do next, what makes sense for the collaborative, what's exciting to us, and what do we want to improve. So as I think about what makes a good quality measure for this collaborative, it's got to be important in order for us to want to spend our time on it. And it has to be easy to measure so that we're not asking you to do a lot of extra work, so that the data is clear and trustworthy. And so it's equal and fair, whether you work in a large practice or an independent practice. And surprisingly, that's like a small number of things that fit into that Venn diagram. So I'm going to tell you about some of the things our coordinating center teams has been thinking about that we think are important, but maybe not the best things to focus on in the next year, and then ask you to brainstorm a little bit about an idea that we're interested in exploring more. So the first is eGFR measurement, which is the other half of the kidney health index. This is a HEDIS measure. It's obviously very important. We have the data available, but we're already doing really well. We're at 92%, and frankly, I'm not sure how much more improvement there is. So, maybe not the best thing to pick as a quality improvement measure versus quality management. The second thing is retinopathy screening. Again, very important. It's also something that we're measured on for HEDIS. But, as most of us are in primary care practices, endocrinology and nephrology, we don't have control over the CPT codes placed by our optometry and ophthalmology colleagues. And, certainly other than ensuring that we've placed referrals and encouraging patients to go get that testing done, it's hard for me to want to focus our energy on something where maybe we need to engage with those other professionals, but maybe not something that I want to put us in charge of. The third thing is measuring blood pressure. Super important. I think we've all got a lot of patients who are walking around with higher blood pressure and would be very, very important to manage. At MCT2D, we don't get the data from exactly the same places that we get it for our HEDIS measurement for our organization. So it's a little harder for us to exclude that high blood pressure medicine from the emergency room. Or from urgent care, or to import all of the home blood pressure readings that you all have access to. So we're going to start monitoring this. We're going to put it on the dashboard to see how we're doing, but I don't think we're quite ready to put that in as a pay-for-performance quality measure at this point. So the topic that I really want to engage you about is thinking about cholesterol management or statin use. And at this point, I'm going to ask you to open your folder. And there will be a handout in there that has 4 questions, and you're going to reference that in just a second. So why think about cholesterol management? It's aligned again with HEDIS. We're already being measured on it. It's important. What are some cons? There are patients who pay out of pocket for their statins, just like there are patients who are getting their expensive diabetes medicine from patients' assistance programs, and we can't account for that. So we're never going to be at 100%. And there are certain exclusions that might be more challenging for us to measure in MCT2D. So what I wanted to bring to you was one of our patient advisors, Larry Davis, when we asked our advisory board, what should we work on next, and what he said about talking about statins.
I take atorvastatin, and the thing is, to be honest, I know it's doing with my cholesterol, whatever, something like that. But it's a shame that I'm not more informed about it. I mean, I go to my PCP, we just do the checklist. Well, you still taking this? Are you out of it? And that's about the end of it, and then we get to talk about other things and never really go into the specific medications that I'm on, for example, the atorvastatin. And I'll be quite honest, this particular patient needs to be reminded that I need to know more about this medication I'm taking and why, and what it's doing for me, and how to measure that if it's working for me. I just need to know more.
Larry came to one of our regional meetings and he was very chuffed to see himself on the big screen. I don't know that I need to sell statin therapy to everyone in this room. It's obviously a really important part of cardiovascular prevention. We know that people with type 2 diabetes have a higher risk for cardiovascular disease and are more likely to die of cardiovascular disease. And these medications are effective. For every 39 milligrams drop in LDL, it lowers your cardiovascular risk by about 20%. And this is in all of our major guidelines. So before I have you kind of brainstorm about where we should go on this, I'm just going to share a little bit about what HEDIS is measuring. The big differences here being they have type 1 and type 2. We're only working on type 2 diabetes at MCT2D. And there's two different measures on our HEDIS measure. One is the received statin therapy and the other is statin adherence. And so I think we're just going to focus on getting any prescription for statin therapy at this point. And we're doing okay. So HEDIS, we're doing around 60-ish% in commercial and 80% for Medicare. And then you look at that same data from MCT2D, because it's coming from different places, from your electronic health records and from claims, we can see our collaborative average is 68%, but we've got really wide variability. One of our practices is at 92%, this is great, and someone's at 42%. And we've got a 90th percentile here. So we can see a gap between our average and where we might think of as our bar. And so we asked our physician organization on some small group calls recently about what they thought the barriers were. Obviously, like patient reluctance to take medications came up, that idea of claims data, what if you're buying it out of pocket, and documenting exclusions. I didn't realize you have to put statin myalgia as a diagnosis every year or it's not counted as an exclusion. And then we asked them, what do you think we need? What do you think we need from MCT2D? And education for patients, education for clinicians, and then some resources in terms of what the challenges are and having those really good conversations with patients to help them reach their own health goals. So I am not proposing that we, measure and pay for performance on percent statin prescribing next year, but we would like to get some more information about what the barriers are with our patients. And what I'd like your feedback about is potentially getting more information about what those barriers are in your practices. So we may end up developing some patient education materials, and we may end up, instead of a performance measure, thinking about a patient-reported outcome measure. So thinking about surveying your patient practice about what their experience has been taking or not taking statins. And so some of the things that we might want to measure or ask them about is their awareness of what is it for, like Larry said, beliefs, side effect concerns, their trust, etc. And again, I think we're going to start gathering information, but maybe not proposing a pay for performance measure at this time. And so if you'll spend just a couple of minutes continuing to fill out that form, then I'm going to ask you to just share around in the table the answer to this question. What do you think we should ask patients? If we're asking, why aren't you taking a statin, or what are the barriers? What do you think we should explore? And then I'll ask for a couple of patients to report that. A couple of patients, you're not patients. We're all patients. Everyone here is a patient in some way. A couple of you to report out in a few minutes. All right, so if you haven't yet, maybe share around with the folks at your table. discuss any particular topics that you think we should explore more into? I hate to break up good conversation, which we're balancing with getting you out of here on time. But would anyone be willing to raise your hand and just share any of your thoughts or insights about kind of what some of these barriers are and what we want to try to explore to understand why we're not at 90% staff use? Anyone willing to share?
So I already do this a lot with my job. It's not my favorite thing to do, I will admit. But I think a lot of patients are just misinformed with it. And I think that instead of focusing, well, I think we like to focus on side effects and things like that too, but also the benefit of it. Why are we wanting the patient to be on this? Because that's the biggest answer that I think they don't get and they need to know.
Yeah, I love that idea of like, if you're in a fight with someone, convincing them to do something that they don't want to do, it's really hard to win. Anything else? Go ahead.
Okay.
Yeah.
We talked about misinformation about statins. Patients think they're gonna be on the muscle aches and pains. They think they're gonna get dementia. You know, they find out all of this information. I think also low perceived risk of heart disease. They don't really know, especially if their cholesterol level is normal. They don't understand the association between heart disease and diabetes. And then one of the questions, or a couple of the questions we had is, you know, making sure the patient understands why they're taking the statin, and also asking them what would make them more comfortable taking the statin. So trying to address their specific barriers.
I didn't say write down all these excellent thoughts on a piece of paper so that we can take them and create our next products from them. Maybe one last person. We can move on if no one else has anything burning to share. All right, thank you so much. We really do want your feedback and input within this small circle of like what we can measure and what's really important to us. But again, I think as Jake was eloquently showing you, continuing to work on our data with MCT2D. So I'm going to turn it over to Dr. Iyengar. Thank you so much for being here tonight. And she's going to talk to us about some endocrinology case studies.
Thank you. Good to see everyone. So we asked our endocrinologists within the collaborative to try to submit some cases that they thought might be interesting for us to discuss. And the same type of case kind of kept coming up over and over and over again. So we selected two of these cases. They're not my personal cases, but they are cases from real patients that were submitted by members of the collaborative. And you'll see that they're the same diagnosis, but we kind of wanted to bring out some different aspects of this type of case. Ooh, I'm going the wrong way. Here we go. So we have first case, 55-year-old man referred to endocrinology for diabetes management. Type 2 diagnosis was made in 2005 at the age of 37. Past medical history also noted for depression, MASLD, GERD, migraines, hyperlipidemia, hypertension, obesity, OSA, kind of a lot of things that are all kind of part and parcel sometimes of type 2 diabetes, right? So nothing that's ringing any like red flags here. In terms of medication regimen, they were taking Tresiba 14 units twice per day, Novolog 9 units with meals. So kind of a pretty like balanced basal bolus regimen. Metformin 1,000 milligrams twice a day and Rybelsus 14. And then mom and sister had diabetes. But they had this kind of interesting history timeline when they kind of dug a little bit more into like what their diabetes history was, which is that they originally, when they were diagnosed, way back, they were being managed in North Carolina. They, at that time, in July of 2015, they were taking Lantus, metformin, and Invokana. And the Invokana had been started in May. And then shortly thereafter, in July, they presented with nausea, vomiting, and positive ketones. And they had a bit of an anion gap. They're a little acidotic. Their A1C wasn't crazy. And it was kind of called like mild DKA. And they were discharged without the Invokana. Then what happens next? Someone thinks, Invokana, that's a good medicine. We should start that back again. Except for this time, you got a problem. This time they're not on insulin, right? So this time they're on Invokana, metformin, combination pill, and Victoza, no insulin. So what happens? They're found to have a blood sugar of 600 in clinic with nausea and vomiting, and they're sent to the ER. They had a big old iron gap this time around, really high beta hydroxybutyrate. So that's their ketones, right? And their A1C is sky high, 13.5. So this is raising a little bit of a red flag here, right? Like they basically like failed non-insulin treatment, and they ended up with DKA a second time when they're on their SGLT2 inhibitor. So they were discharged home without their Invokana, and they were started on basal bolus insulin. Well, if we thought starting them on an SGLT inhibitor 2 times wasn't enough, we decided to do it a third time. So this time they got started on Jardiance. They had been on Novolog with like their largest meals as well as metformin. They get put on the Jardiance. All it takes this time is like 1 week for them to end up in DKA, and then they were discharged home without the Jardiance. And then this is when they established with our provider. They said, there's some warning things here, right? So what they did, they made some medication changes, but the most important thing here is they checked a C-peptide, which was normal, right? Okay. So this still could be type 2 diabetes. But then they checked it, their suspicion, their antenna was raised. So they went ahead and they ordered a GAD, which is negative. They ordered an IA2, which is negative. And good on them, they ordered a zinc transporter 8. So they got into some of the esoteric antibodies. And yes, they indeed have antibodies. These are type 1 diabetes antibodies, right? That's one of the antibodies that's associated with type 1. So I think all the endocrinologists in the audience, what is the diagnosis? LADA, excellent. So first, what I wanted to illustrate with this first case is when should we be suspecting LADA in our patients? So LADA is a slowly progressive autoimmune diabetes. Generally, the definitions of it used to incorporate like age greater than 30. So tends to be a little bit younger than some of our other folks with type 2 diabetes, but still a later age of onset than what we see with typical type 1, right? Average age of type 1 onset is age 9. It shares features of both type 1 and type 2 diabetes. It accounts for 2 to 12% of all adult onset diabetes. So part of the reason why I think a lot of collaborative members were able to submit a case for this is something we actually see. Like, I think all of the endocrinologists probably have several of these cases, people who came to them originally sort of labeled as type 2, where we discovered that no, they're actually probably LADA. And so then in terms of definition, the key part is those bullet points here, that they have positive islet autoantibodies like a type 1, and it initially does not require insulin though. So it kind of looks like a type 2. So they kind of got features of both. And this is what leads a lot of folks to use the term like diabetes 1.5 when they're describing this, right? Because it's someone who sort of like starts like a type 2 and then they go and they start to behave like a type 1. I tend to like to think about it in my head often when I'm classifying diabetes. I sort of ask myself, like, does this patient have antibodies? And do they have beta cells, right? And there's some classification schemes where that's actually sort of like part of the classification where we say, okay, are they antibody positive or negative? And do they have beta cells or not, right? But in terms of LADA is going to be that cross section where they do have antibodies, but then they may not require insulin right away because they may have positive C-peptide. They might be able to generate some of their own insulin there, particularly in the beginning. But it does progress to insulin dependence over months or years. And so why does it matter that we can recognize LADA? Well, because there's a different prognosis and treatment. That's the treatment course is going to vary versus regular type 2, an earlier insulin requirement, and you can get better beta cell preservation with appropriate therapy. And I guess this is where I'll take a moment to just mention, I think a lot of times when we're treating patients with type 2, we see putting them on insulin as a failure. And so when we get these patients with LADA, sometimes they can be really frustrated. Sometimes they come to us if they don't know they have LADA, they don't really understand, like, why am I needing insulin? I'm doing everything right. What's going on here? And likewise, sometimes even if I have patients with known LADA, if they're able to be managed with non-insulin agents at the start, sometimes they can get frustrated or sad or feel defeated when they end up needing insulin. And that's where I have to have a little bit of a heart-to-heart with them and say, no, this isn't you. This is your pancreas, right? Like your pancreas is under attack. So the fact that you're needing insulin is not a treatment failure. It's not a reflection on like how you're approaching your diabetes, but it is, unfortunately, this disease is more progressive than like the kind of standard type 2 course. And so that they shouldn't like feel guilty about needing to be put on insulin or feel like that's a sign that, they're otherwise failing in their treatment management. All right. So when should we suspect LADA? So patients who are younger at diagnosis, normal BMI or lean body habitus, absence of other metabolic syndrome features, and then a personal or family history of autoimmune disease. Obviously, like if someone tells you they have a family member with type 1, right, that also is always going to raise a red flag. That's going to be grouped in with those autoimmune diseases. We know that autoimmune diseases like to run in packs. So, and then the clinical course, we talked about how there can be a progression to insulin requirement. I would actually say like usually not, like if someone progresses to insulin within the first 6 months, I often will just label them type 1, but it's the fact that they were able to be successfully treated without insulin to start, and then they went on to progress. Poor response to non-diabetes medications, unexplained weight loss, difficult achieving glycemic goals. And then this one, which was the clue in our case, which is a history of DKA with or without SGLT2 inhibitor use. And so how would you test for LADA? You would order your C-peptide with a random glucose, right? So remember that like when insulin's being made, C-peptide is a byproduct of the body making insulin. And we like to measure C-peptide because it's a little more stable versus insulin levels, which are really dynamic and can change quickly over time. So when I'm talking about does the patient have C-peptide, I'm talking about like, does that patient make insulin, right? That's our more stable marker of is the patient making insulin. Still varies. That's why we like to know the glucose, right? Like if the glucose is sky high, sometimes there's actually this glucotoxicity thing that can actually kind of suppress their insulin production, give you a low C-peptide. So usually historically you want the glucose under 225 at the time that you check it. But likewise, sometimes if someone's having a low glucose at the time that C-peptide is being drawn, right, you wouldn't expect the body to be making a lot of insulin like around that time when their glucose is low. And then in terms of antibodies, the most common are going to be GAD, just the same way with type 1, the most common antibody is GAD. That would be the most common in LADA. But you can consider these other antibodies if you remain suspicious, which is what happened in this case. So they did a good job making that diagnosis. And so 90% it's going to be GAD, but there's this like rough other percentage that might test positive. And remember, some people can have like multiple antibodies. All right. So let's do another case. So this is a 62-year-old. She was referred to endocrinology for diabetes management. She had type 2 diabetes diagnosed at the age of 57. Her weight at the time of diagnosis was 140 pounds, although she did have a max lifetime weight of 230. She has hypertension, dyslipidemia, depression, and she is managed on metformin, glipizide, Mounjaro, Jardiance, and just like a whiff of Lantus. And then she has multiple family members with type 2 diabetes. So her weight at the time, her BMI was 18, her weight was 104 pounds. She had an A1C of 15.9%. Ooh, high. Currently now at 8.5%. Her C-peptide was in the normal range. Again, it's like pretty dynamic what a normal range of a C-peptide is, but she's antibody positive. So we can go ahead and say like this matches with LADA, right? Positive antibodies, still making some insulin, and not like a classic type 1 where they're requiring, like in this case, she's on a little bit of basal insulin, but didn't require basal insulin from the start, and isn't on like sort of the classic basal bolus we'd expect to be required of someone with type 1. And then when they looked at their CGM, average glucose was 196, 45% time in range, but intermittent overnight hypoglycemia with prandial excursions, right? So just that little bit of Lantus is making them low overnight, but then they actually just aren't able to generate enough insulin to keep up with what they're eating. All right, so how would we think about like, that patient obviously is not optimized. So how might we like, their A1C is 8.5, right? Better than the 15 that they started on. But like, what can we do to manage these patients with LADA? So we think about the management of LADA. One way to think about it is based on C-peptide levels. So there are clinical guidelines that will help you manage LADA based on the C-peptide levels. And as we kind of talked about, right, the reason why we think about C-peptide levels as sort of our distinguishing factor is LADA sometimes behaves like type 2, and sometimes it behaves like type 1. And so you're going to want to use that C-peptide to help like classify, like where do we think the patient is in that spectrum. One thing to be very careful of, though, when you're using the C-peptides, especially comparing to the guidelines, which are like European guidelines, would be to make sure that there's different like units of measure for C-peptides. So just always make sure that you're like checking the units and that what's used in your lab is matching like what you're seeing in the guidelines. So let's talk about it. So if someone's low C-peptide, right, that means they're not making insulin. So now they're antibody positive and they're not making much or any insulin, right? So we're going to treat that similar to someone with type 1, right? Because, if you check a GAD and a C-peptide in someone with type 1, you'll often see positive antibodies and like negative or extremely low C-peptide, right? And so typically you're going to use basal bolus insulin in these patients. You're going to avoid things like SGLT2 inhibitors for the same reason that we avoid them in folks with type 1. And I will say, like, I always think about, like, in these patients, you're worried that they're not making insulin. And in my brain, I always kind of separate, like, insulin has a job to lower blood sugar, but insulin has a job to like block keto acid formation. And I always have to remember that those are a little bit separate, right? Like they go hand in hand sometimes, but not perfectly, right? So if you remember back to med school when you were taught how to manage DKA, right? you first, give the patient IV insulin to try to pull that sugar down. But then you actually give them sugar with insulin. Why? Because like you need to clear the ketones, right? And so you need to be able to give them more insulin than what it takes. It was easier to bring the sugar down with insulin than it was to actually clear the ketones. So that's why those two roles of insulin go hand in hand, but they're not always like perfectly aligned. And so with these patients, when you put them on an SGLT2 inhibitor, the fear is they won't get very high sugar, but they'll generate the ketones, right? That's why these are at risk for euglycemic DKA, right? The sugar won't be high, but they'll still be generating ketones. That's the fear. All right, if someone has high C-peptide, they're making lots of insulin. So you can treat them more like a type 2, right? Fair game. You might want to avoid sulfonylureas. The thought is those are not like beta cell preserving therapies, right? Sulfonylureas tell you to make insulin no matter where your sugar's at. They just kind of tell the pancreas you got to churn out some insulin production. They're already churning out enough insulin. There's some thought that these sulfonylureas are not beta cell preserving the way a therapy like a GLP-1 might be beta cell preserving. But then you get in this pesky intermediate category, right? So if someone has an intermediate C-peptide, what you might consider doing, and it still gives all of these as options, but you could consider checking C-peptides at regular intervals, or if glycemic control deteriorates, right? And so here's like the controversial part is like, when can we still safely use an SGLT2 inhibitor in someone with LADA? And the purpose of this slide is to let you know that like you could, like it's possible. I have definitely prescribed SGLT2 inhibitors for my patients with LADA. I can probably count it on one hand, but I've done it. But if this isn't something that you're familiar with or comfortable with, maybe just don't, right? Like it's probably just safer if you just don't do that if LADA is not something that you have an expertise in, right? So I would say if you're wanting to be on the safe side, probably no to the SGLT2 inhibitor. But if you feel like you have a really good feel on like, yes, this patient's like kind of behaving more like a type 2, or even if they're in that intermediate category, but you think they're low risk for other reasons, it is possible to do this, but just you really got to know what you're doing. So I'd be careful with it. So who's at risk for SGLT2 inhibitor associated DKA, right? So anytime there's any kind of stress, infection, surgery, malignancy, that kind of goes along with that surgery, right? Surgery causes surgical stress, but remember, it also makes patients like NPO, right? So there's a warning out that you're supposed to stop SGLT2 inhibitors 3 days prior to surgery, both because you're making the patient NPO, which is going to make them more prone to make ketones, but then you're following that up with like surgical stress, right? Which is also going to make them more prone. So it ends up being sort of a double whammy. So there is a recommendation out there to hold your SGLT2 inhibitors 3 days prior to surgery. Other things that would put people at risk: alcohol use, low BMI. We kind of talked about the prolonged fasting, right? And then like very low carbohydrate diets. And anytime where someone's dehydrated or they have decreased oral intake. So going back to the case, so this again was one of our collaborative members. So they discussed how they managed this. In this case, short-acting insulin was added to meals, initially as injections, and then they were actually transitioned to a secure disposable patch pump. So good on them. And then after shared decision making, they decided to discontinue the glipizide. Remember, sulfonylureas are not beta cell preserving, so we usually don't prefer them. They continued the Jardiance, but they did have a risk benefits discussion with the patient about DKA. And I will say, I always feel a little more comfortable with an SGLT2 when they're on the insulin and remind them that they can't discontinue the insulin, right? Because again, they're going to have that insulin to block the ketosis. Metformin was continued, and then they were continued on their Mounjaro. All right. Any questions for me? Going once? Going twice? All right. Well, I'll be in the back, but I see we have our nephrology colleague coming on up. So.
Hey, everybody. I do realize I'm keeping you from leaving, so I'm going to try to keep moving along here. Okay. This is going to be interactive, so I really hope, sorry for those of you back there, but I'll do my best to try to peek out there. But those of you back there might need to shout out your answers. Okay. So similar to what we did for endocrinology, we asked the nephrology practices to give us some cases of good examples where they thought there was good learning points for primary care with patients. And so we're going to go through one of these. It's going to be a little bit of a choose your own adventure as we go along. So this is a 67-year-old woman. She comes into your practice to establish care with you. Her comorbidities include hypertension, diabetes, obesity, morbid obesity with BMI of 41. Her blood pressure is not perfectly well controlled. Her medications include metformin, glyburide, lisinopril, and a statin. These are her labs. Her creatinine is maybe mildly elevated at 1.12, giving an eGFR of 54, which would qualify for stage 3A CKD, and LDL is 100. And notably, her urine albumin to creatinine ratio is 3,000. Okay, so I know what you're thinking, like, what was the previous primary care doing, right? But you can't help that. Now it's your patient. Okay, so the first question I have for you guys is, what do you think is going on here? What's the cause of her mild CKD but significant proteinuria at this point? Yeah, yes, it could absolutely be diabetes. Any other choices, or do you want any more information? Hypertension, okay. Blood pressure is not perfectly well controlled. Not crazy, but not at goal. Okay. Oh, okay. Nephrologist in the front row here? Yeah. FSGS. Okay. Yeah. You can get FSGS, focal segmental glomerulosclerosis, from a variety of causes, including obesity. Okay. Great. So, and how many of you would refer to nephrology at this point? Okay. Yeah, a few of you. Okay. What makes you want to refer to nephrology at this point?
I mean, it's sort of like pre-diabetes. Like, I feel like if we wait much longer, we might miss it both.
Okay, good. I love the faith that you place in us. That's good. I really appreciate that. No, in all seriousness, I think, yeah, early on, and one of the things that's been kind of fun for me is, I would say over the last 10 years, I'm seeing patients a lot earlier, which is great, because when I finished my fellowship 20 years ago, it wasn't uncommon to see patients come into the office with GFRs of like 20, low 30s. And I mean, really on my first visit, I'm starting to talk to them about the possibility of needing a kidney transplant, dialysis down the line, and things like that. These days, I can have conversations mostly with patients early on where I'm pretty confident we're going to be able to avoid those outcomes. So, okay. So for this first case, this is meant to be a little bit of a curveball. So what if I told you that the diabetes is actually fairly new in this patient? Just a few years ago, it's actually been pretty well controlled. Just a year ago, she didn't have significant albuminuria. And actually on presentation, she has significant edema, and her albumin's actually only 2.8, so pretty low. So you do refer this patient to nephrology. Nephrology then sticks a big needle in their back and gets a biopsy for a suspected nephrotic syndrome, meaning the criteria for nephrotic syndrome here, and comes up with a diagnosis of membranous nephropathy, which would probably be the most common nephrotic syndrome in this age group. And of course, the importance of this is because you would treat this very differently. You'd still treat the diabetes, the blood pressure and such, but this would require specific treatment in this case, and immunosuppression to reduce an autoantibody that's implicated in membranous. Okay, so the point of this first case is just to make you think about the times when patients presenting who have diabetes with some kidney disease, when it might not be diabetes. A majority of the time, it's going to be diabetes, but these are some of the things to think about. If you see, like in this case, a rapid onset of proteinuria, so instead of like over years where you can see it coming, like a pretty rapid onset, meaning weeks to months, okay? And certainly to that very heavy nephrotic range. Other features of like the nephrotic syndrome, such as the hypoalbuminemia, the significant peripheral edema, and of course the heavy proteinuria. A significant decline in kidney function. Again, in diabetes, gradually, we sometimes see an accelerated course later, but usually you don't see a big dropping off a cliff early on. So if you see that, definitely think about what else could be going on. And then other secondary risk factors, like we talked about, obesity being a potential risk factor. NSAIDs can cause a minimal change disease, which can present with this. if they have like a hypercalcemia or something that makes you think maybe they might have something else going on, like a myeloma or something that could present like this. So there's some other things to think of. The classic that we're used to, of course, the typical features would be if they've had the longstanding history of diabetes. Again, you can usually see if it's been checked. Hopefully, it's been checked. The albuminuria progressing over time, and typically other microvascular type complications like retinopathy and peripheral neuropathy. Okay, but in actuality, this case, this patient did have diabetic nephropathy. You get the records from the previous primary care, and you do see that there is gradually worsening albuminuria over the past 6 or 7 years. And she also has a known history of diabetic retinopathy, so a lot more to make you think that this is primarily diabetes. Okay, so what do you want to do for this patient next? And I'll show up here again her characteristics and what med she's on. What do you guys want to do now? Other than, of course, counseling, in addition to counseling her about lifestyle, healthy lifestyle measures. No, not you. I mean, have you guys seen patients like this?
Yeah.
Yeah, okay.
We already know her diagnosis.
Yeah, this is now, you feel pretty confident this is diabetic nephropathy now. Okay, I heard an SGLT2. Got to vote for that. Okay. Anything else? Complete unanimous? Yeah. Okay, better blood pressure control. So her lisinopril is not maxed, so you could certainly think about bumping up her lisinopril, which should also help with the albuminuria. Anything else? Okay, so definitely everybody's all on board the SGLT2 inhibitor bandwagon, and that's what you decide to do. Okay, so you start her on Jardiance, 10 milligrams. About a month later, you're following up labs. Her albumin to creatinine ratio has come down a little bit. It's still pretty early. It's only been a month, but it's moving in the right direction, maybe from 3,000 to about 2,700. Still obviously quite elevated. And her GFR is down a little bit from 46 down to 55. Anybody worried about that? No? A little bit?
Yeah.
Okay, yeah. So what would you do?
I would find out if she's changed anything with her lifestyle, she started taking NSAIDs or anything that could be
Okay.
affecting kidney function. Talked about her hydration status, especially with the Jardians,
Yeah, absolutely.
and then recheck it probably in a month.
Okay, I love it. So just for, if you couldn't hear, make sure there was nothing else going on. She didn't start taking NSAID, something else that could have contributed to the worsening. Hydration, of course. They're not very potent diuretics, but she's not already on a diuretic, but somebody who else, another patient who might already be on another diuretic, that is a potential risk. And just the lifestyle measures in general, and then maybe following it up. So, okay, great. Would anybody stop the medicine, stop the Jardiance at this point? No? Okay, I see a lot of negative, and I'm sorry, didn't quite catch that. Yeah, I purposely didn't give you that. I don't know, what do you want her A1C to be?
Yeah.
Under 7, sounds good to me. All right, A1C is under 7. All right, so the point here is that you should expect some degree in eGFR decline. It's absolutely reasonable to do everything you mentioned, okay? And I agree with those of you that were vigorously shaking your head about not stopping the medicine, okay? Rechecking it is okay, but making sure that so monitoring it is important, but the medicine is helpful and it's expected to decrease the GFR. So kind of try to show this here. This is like a normal kidney function, and then over time, we lose a little bit of kidney function with age. The nephrology rule of thumb is 1% per year after the age of 40. So you see a little bit of decline, but they should never get to end-stage renal disease with the natural history. With chronic kidney disease, you can, of course, unfortunately get an accelerated decline that can lead to end-stage kidney disease. And what we're hoping to do with medicines like the SGLT2 inhibitor, you do know that there can be an upfront loss in GFR, okay? But what you're hoping to do is actually change that curve from the red here, the CKD untreated curve, to the green. And obviously the benefit then is this time until getting to kidney failure, which hopefully is actually their entire life. Like hopefully they never get there if you can get this started early enough, okay? And I'll just also point out that this is a reversible effect of the SGLT2 inhibitors. Okay, this is a physiologic effect. You're not hurting the kidneys in most cases. This is a physiologic effect that is reversible if you stop the med. Okay, one pro tip from that I've learned the hard way. How many of you have engineer patients? Yeah, you guys know what I'm talking about, right? Right, the ones that show up with the graphs and everything, and they send you the printed outputs of their blood pressures and their EGFRs and to the like third decimal place. Yeah, so if you're starting an SGLT2 a patient in any patient really, but especially your engineer patients, warn them about the GFR drop, because I've gotten some very angry portal messages saying like, the hope you convinced me to do this to protect my kidneys, and then my GFR went down. This is the exact opposite. So it's not just for you to know that this is something that's expected and that there's benefit in the long term, but to explain it to your patients as well. So I'm having a little PTSD. Just last week, I saw a man. He was accompanied by his wife. They were both engineers. They both had a stack of paperwork, and I literally drew this out on the paper you tear away on the thing. I drew this out for them. So, okay. So this is the question here, of course, is can SGLT2 inhibitors cause AKI? When they did the clinical trials and they looked at AKI as a safety outcome, actually the risk is lower in patients that received SGLT2. So SGLT2s are actually considered protective against AKI. However, there can be times when, of course, as you were alluding to in the front here, where patients can get pre-renal, you can get an AKI. This is going to be people who are more prone to volume depletion. Say they have gastroparesis, they can't hydrate as well. They're already, say, on a loop diuretic for other reasons or something like that. Those are the patients you're going to want to pay a little bit closer attention to in terms of volume. When I would be concerned is if you have a fall in EGFR greater than 30%, that's not expected. That's not probably the physiologic. I would, in that case, hold the medicine and kind of find out more and repeat the labs and see what's going on. But if it's in that 10 to 20% range, stay the course and just kind of monitor. Okay, so the case is continued. The Jardiance is doing great because the A1C is so great. You're able to stop the glyburide, right? And then they've lost a little bit of weight with the medicine, also probably because he stopped the glyburide. And a few months later, the GFR is stable and their albumin to creatinine ratio has improved. In fact, it's now halved, but it's still 1,500. What do you guys want to do now? You want to make any changes or stay the course? Yeah. Corindia, okay, great. Other thoughts? A GLP-1, okay, great. Other thoughts? I think those are both very reasonable options, okay? So yeah, so you decide to go with the GLP-1 first, okay? In this case, you decide to add Mounjaro, starting at the initial tolerance dose and then building up to full dose over the next several months. They have a pretty good response, a significant weight loss. BMI is still elevated, but significantly down. She started at 41, remember? And along with that, her EGFR is stable, even slightly improved. And her albumin to creatinine ratio continues to improve, okay? All the way down to 360, which is almost a 90% drop from the original, but is still actually in the A3 range, okay? So now what do you guys want to do? Anything, stay the course, pat yourself on the back. Yeah, stay the course, okay? No, this is just the GLP. So now you want Corindia, right? You wanted Corindia before, so you definitely want it now. Okay. All right. Yes. So this is a patient who is still, even though you've two ways of looking at this, right? Significant improvement, which is great, but still arguably in the high risk group, just not quite as high risk as before. Okay. So this is somebody where with the persistent albuminuria, significant albuminuria, you really could think about adding this fourth pillar, as it were, as we'll talk about, the crandierfinerenone. So you add this. 6 months later, the albuminuria is almost down to is down into A2 range. Okay, not quite normal, but a tremendous improvement from before. EGFR is mostly holding its own. Who's worried about this potassium of 5.2? Anybody worried about the potassium of 5.2? I know Dr. Plattner is not worried about nephrologists, like we don't get out of bed for potassium less than 7, I mean, we're a little desensitized, so. Show me sine waves and then I'll show up in the, but, okay, good. So nobody's really worried about a potassium of 5.2? Would you guys do anything? Would you stop the medicine? You're waffling now. You wanted the Crendia. You wouldn't stop it. Okay. Yeah, no, it almost certainly is the cause. I mean, she's also on lisinopril, right? So she's on a couple of medicines, arguably. So I guess what I would say is, all kidding aside about the potassiums of 7, 5.2 is obviously elevated. Patients are also going to see this. What you don't know is is it sometimes 5.5 also, and it's now 5.2, and because it's going to range. So if you're concerned about this, and it's reasonable to be concerned about this, I would just point out that there are things to do other than stopping either her ACE or her finerenone. And I would think about doing those things potentially first before you take away these medicines that have proven benefit in this kind of clinical situation. So a couple of things include counseling the patient on their diet, okay, and seeing how much potassium intake they're taking. There's so many staples that are high in potassium: potatoes, tomatoes. Everybody knows about bananas, but citrus fruits like oranges and things like that. So working with your dietitians, okay, directing them, say, to National Kidney Foundation website where they have information sheets. And it's not, I try to get my patients, I try not to tell them, you can't have this, you can't have that. It's about moderation, and it's about trying to pick alternatives. So for example, we have handouts that are these are your high potassium foods, these are your lower potassium foods. Hey, I know you really like fruit. Apples is a low, you like oranges, but do you also like apples? If so, how about choosing more apples than oranges, that kind of thing, to work with the patients. Sweet potatoes instead of potatoes, to try to work around that. There are also medicines to lower potassium. I personally hate chasing a medicine side effect with even more medicines, like with those potassium binders. However, if their blood pressure still isn't under control, like somebody brought up earlier, a diuretic, okay? A diuretic like a thiazide diuretic or even a loop diuretic can help with the caloresis and help to control their potassium and allow you to use these other medicines. Okay, so just a couple of things to think about. I see a lot of times people taking off medicines for mild elevated potassium without trying some of these other measures first. And I think that's a potential missed opportunity. Okay, so this again is an example of where we've gone through with what we are calling the 4 pillars now. Okay, and it's so exciting because when I was a fellow, we had 1 pillar, this whole temple was falling down on itself. I mean, we're just talking about kidney failure all the time. Okay, but now we have all of these 4 pillars: the ACE ARBs, which we've had for a long time, the SGLT2s, the non-steroidal MRAs, which is the crandierfinerenone, and then the GLPs. All have been shown in large randomized control trials to decrease the rate of chronic kidney disease progression, and even to reduce kidney failure in the case, especially with the SGLT2 inhibitors. So it's a pretty exciting time, and hopefully this case gives an example of how you might use all of these. We went through in a certain order. Doesn't have to be that order. For those of you that said GLP for the first med instead of SGLT, that's totally fine from my perspective. This wasn't meant to be like, this is the only right way to do it, but this is meant to show you how you might use actually all four of these, get patients on it, the kinds of things to watch for, the pitfalls, okay? I also like to remind people that these pillars are built on a foundation of lifestyle changes. So always important to remember counseling your patients. I know none of us have enough time to do this, unfortunately, but working with our teammates, the dietitians, the nurses, the care planners, to remind people about the lifestyle changes, especially diet and physical activity. Okay, but we're not quite done with the case. So last twist, plot twist. So unfortunately, this patient's admitted to the hospital. She catches the flu, gets into the hospital. She had some nausea and vomiting and diarrhea from the flu. And when she shows up, she has an AKI. Her creatinine was elevated to 1.4 from a baseline of around 1.2. Okay. And so appropriately, they treat her in the hospital. They get her feeling better. They hold her lisinopril and her Jardiance, right? This is what we typically do. These are medicines that decrease the GFR. So when you show up with an AKI, it's appropriate. We'll stop those medicines. They don't restart them at discharge, and they send them to follow up with you, right? That's what we do in the hospital. Say, go follow up with your primary care. It's their problem now. No. So she comes in for post-hospitalization follow-up. Her blood pressure's back up a little bit, okay, because obviously you've held her blood pressure medicines. Her creatinine is not quite back to baseline, okay, around 1.4, still a little bit above better, but still not back to baseline. And her albumin to creatinine ratio is back up again, probably the inflammation and also being off of these meds, okay? So this is a little bit of a multiple choice now. What do you guys want to do? Do you want to just watch, do nothing for now, see her back, check her kidney function later? Do you want to restart the Jardiance? Do you want to restart the lisinopril or both? Yeah, I just gave you 4 choices and you said yes. You're like my kids. I don't like, they don't like. Which one? Lisinopril, you like the lisinopril, right? You got some blood pressure benefit and things. Okay. All right. Anybody else? Don't let me just pick on her. I mean, come on, somebody, who would not restart anything? Just kind of watch, just chill. Nobody. Okay. All right. Good. Who would restart the Jardiance? Okay. I get a few people back there. Okay. Yeah. Who would restart both? Okay. All right. Great. Some brave souls. I like it. Okay. Great. Although like brave, like their hand went up like this, but I still saw it. So, okay. So, once again, I don't think there's an absolute right or wrong answer here. I do think restarting the medicine is going to be your goal. Okay. Many times I'm still a little bit conservative. I will usually start one and then add the other. The thing I have to try to fight against is that therapeutic inertia and remembering to add them back and not just keep putting it off, okay? Because before you know it, 6 months is 12 months is 2 years, and the patients aren't on it, and now their kidney disease is progressing, okay? And I think there is some good evidence to support restarting these medicines, okay? This is a study that specifically looked at RAS blockade, so your ACEs or ARBs, after an episode of acute kidney injury in patients with diabetic kidney disease, like this patient, okay? This is in vets. What they found was that if you were put on the ACE inhibitor or ARB, you had a higher survival, so lower mortality after an episode of AKI. Okay, so again, very routine to hold these medicines when somebody has an AKI, but it's actually protective if you put it back on. And a really interesting part of this story, because before this study came out, I used to say like, well, let's see if the kidney function can come all the way down. Let's maybe wait and everything. This study separated people into whether they had recovered their kidney function yet or not. Okay. And basically what this curve shows is that the red and blue line are superimposed. Those are the ACE and ARB lines. Okay. So higher survival, whether your kidney function had fully recovered or not. Okay. compared to these two curves where you're not on the medicine. And one of them is if you had recovered your kidney function and one had not. So not a contraindication to restart. And in fact, arguably a reason to restart. Okay. Because you're going to have a better survival, right? Similarly, a very similar study, but looking at SGLT2 inhibitors, again, in patients with diabetic nephropathy after an episode of acute kidney injury. Okay. And here they once again showed that the mortality was lower, or sorry, this was progression of kidney disease, and they showed that that was lower if they were started on an SGLT2 inhibitor. And so these medicines still work. That's what they're supposed to do. They still work even if somebody's had a kidney injury. Again, like you might think, oh, this patient's kidneys are vulnerable. Maybe we shouldn't be hitting them with an SGLT2. But actually, the medicines are still protective in that post-AKI setting. And this basically, we also worry about causing AKI again. This basically shows that the patients on the SGLT2 inhibitor had a lower risk of recurrent acute kidney injury. Okay, so again, those of you that were gung ho about restarting the meds, you guys, to me, that's an evidence-based answer to support that. Okay. Okay, so walking through the case, these are the kind of points that I hopefully was able to make, or you guys made with your answers. Think about the red flags when you might think about a patient with diabetes having something other than just straightforward diabetic kidney disease. If you should expect a 10 to 20% drop in the eGFR with initiation of an SGLT2 inhibitor, and not panic and stop medicines for that, and also warn your patients ahead of time. Hopefully it was clear how we walked through and how you might use the 4 pillars of therapy in a given patient and see that. One comment that came up yesterday, I walked us through the case kind of slowly in terms of the time frame of the case, and somebody at our last regional meeting made the point, it's like, you should have done that a lot faster. Like you should have seen them. And I was like, actually, that's a good point. I'm still not at the point where I'm starting all 4 of these at once in a patient. I just feel like it's a lot. Every medicine has potential side effects. But again, fighting against that therapeutic inertia, seeing your patients back in a timely manner, adding things on so you can get to those 4 pillars is important. So I thought that was a great point that they made yesterday. And then lastly, think about restarting those ACE, ARBs, and or SGLT2 inhibitors when your patients come back to you after a hospitalization with acute kidney injury. So thanks for your interaction, and I'll be happy to answer any questions if anybody has any questions. Yeah.
The 10 to 20% expected drop from starting the SGLT2, when will the kidney function come back up? So
it doesn't necessarily bounce back. Yeah. So that's another thing. It shouldn't keep going down. Okay. And if anything, again, you have that upfront drop. Hopefully it stabilizes as we kind of saw in the case. All right. But no, it shouldn't keep going down, but it may not bounce back. Sometimes it bounces back a little bit. Just the kidney auto-regulates a little bit. But it's not guaranteed that it'll come back unless you stop the med, then it is reversible.
in the urine, is that what you're, like, how do you know that it's working?
Yeah, this is where your urine albumin is the metric that we're following and that I would encourage you to follow to show that improvement. Yep. Other questions? Great. Well, it's late, so I'll finish up, but I'll stick around if anybody has any other questions. So.
Thank you so much, Dr. Appreciate it. Okay, the only thing standing from you and leaving is evaluating the evening. So we're going to ask you to look in your folder one more time. Please leave the survey on statin quality measures on the table. Please fill out that evaluation for tonight. Tell us what you liked and what you didn't like, what we should do more of or differently. Your feedback, again, we're really only here to improve diabetes care for our patients. And so whatever helps us do that most, please share that with us. If you can hand in your badges so we can recycle them on the way out, we'll all be in the back of the room if you have any questions or concerns to raise. We will see you next in person next spring. And have a lovely spring day.